Welcome to this series of lectures in medicine. In this specific series, we have been talking about diabetes, and today we will be talking about macrovascular complications of diabetes. So without further ado, let's get into the lecture. Welcome back. In this session, we will continue with complications of diabetes. In today's session, we will discuss macrovascular complications of diabetes. You can check our other video on acute complications of diabetes, even as we talk about the chronic complications of diabetes. In our outline, we are going to talk about an overview of diabetes so that you can remember what diabetes is, and then we go into chronic complications of diabetes. And in chronic complications, we will talk about the pathophysiology, the presentation, how treatment and management of these complications is done, and what patients can do to prevent these complications. So diabetes mellitus is a group of diseases due to high blood sugars, and insulin controls the entry of glucose to the cell. Glucose in the cell is useful for energy production. Without glucose, the cells cannot make ATPs for their own metabolic needs and for their functions. Diabetes is therefore caused by deficiency of insulin or resistance to insulin, or both of these conditions. So there are two main types of diabetes, that is type 1 and type 2. The classical symptoms of diabetes is polyuria, polydipsia, polyphagia, that is increased urine production, increased thirst, and increased hunger. As we have always talked about, complications of diabetes are in two groups: acute complications and chronic complications. Acute complications are those that take place within 1 to 2 weeks, and they are very fast. They are emergencies and should be treated as such. Chronic complications take a longer time to develop. So acute complications are diabetic ketoacidosis, hypoglycemia, and hyperglycemia. Then chronic complications are divided into two, that is microvascular and macrovascular. In today's episode, we will talk about macrovascular complications of diabetes. So macrovascular complications of diabetes are diseases of the large and the medium-sized blood vessels. So this affects the brain, that is cerebrovascular, the heart, that's coronary artery disease, and the peripheral vascular disease. Long-term complications are becoming more common as people live longer with diabetes. The long-term complications of diabetes can affect every system of the body. Diabetic patients are at 2 to 6 times higher risk of developing these complications than the general population. So macrovascular complications account for most of the morbidity and mortality in patients with diabetes mellitus. So anytime there's this problem, it's usually due to the complications, especially the macrovascular as opposed to microvascular complications. And diabetic patients, for information, are known to have a 2 to 4 times increased risk of cardiovascular disease compared to the non-diabetic counterparts, and this accounts for approximately 80% of mortality and about 75% of hospitalizations in persons with diabetes. That means it really needs to be taken care of. These patients need to prevent or to treat and to be diagnosed early enough so that they don't end up in as mortality statistics. So let us go to pathophysiology of cardiovascular artery disease. So cardiovascular artery disease has 4 common conditions that predispose to this cardiovascular artery disease. So we have atherosclerosis, microangiopathy, diabetic cardiomyopathy, and cardiac autonomic neuropathy. So in brief, atherosclerosis is when the blood vessels thicken, then they sclerose and become thickened by atherosclerotic plaque that eventually blocks the blood vessel. So what this means is that then the tissues being supplied by some of these vessels are not getting enough of the blood supply. So they get ischemic or they get infarcts. And if it is the heart muscle, then there's a likelihood of it getting infarcts, what we would call myocardial infarction. And this patient may get a silent myocardial infarctions. The other thing is microangiopathy. Angiopathy is a condition in which the capillary walls become so thick and weak that they bleed, they leak proteins, and slow the flow of blood. Then we have diabetic cardiomyopathy. Cardiomyopathy decreases the function of diabetic cardiomyocytes, or the cells of the myocardium. There is also interstitial fibrosis of the muscles, and then cardiomyocyte loss, therefore impairing the function of the muscles of the heart. Then there is also, of course, the small blood vessels, which we will discuss later as macrovascular disease, and then the neuropathy. All these things contribute to diabetic cardiomyopathy. The other thing is cardiac autonomic neuropathy, which is a significant cause of morbidity and mortality due to the high risk of cardiac arrhythmias, silent myocardial ischemia, and sudden death. Cardiovascular disease is a major cause of morbidity and mortality in patients with diabetes. Early macrovascular disease is associated with atherosclerotic plaque in the vasculature, supplying blood to the heart, the brain, the limbs, and eventually these vessels get blocked, causing ischemia to the tissues that they are supplying with the blood. So what happens after that is that in the late stages of macrovascular disease involves complete obstruction of the vessels which supplies some of these major organs, and in the heart we have the increased risk of myocardial infarction, like what you can see in this picture. Then we have also risks for stroke, claudication, and gangrene. Cardiovascular disease is a major cause of morbidity and mortality in patients with diabetes. There are several factors or risk factors for coronary artery disease, and one of the things is age, because the vessels are already affected, they are already sclerotic, thickened. Then we have hypertension, dyslipidemias, obesity, physical inactivity, and stress. We will briefly look at some of these as we go. Before we go into those risk factors, let me briefly mention something about heart failure. Diabetes is associated independently with a 2 to 5-fold increase of heart failure compared to those without diabetes, comprising of both systolic and diastolic heart failure. Diabetic patients have a worse outcome once heart failure has developed compared to the rest of the people. The increased risk of heart failure observed in diabetic is multifactorial and can be caused by ischemia, it could be metabolic or myocardial dysfunction. Also note that myocardial infarction is twice as common in men and 3 times as common in women with diabetes compared to their non-diabetic counterparts. For women, this is because of the estrogen, the hormonal levels, and estrogen is also a risk factor for cardiovascular disease. there is a chance that there is a likelihood of a second myocardial infarction if you've already had a myocardial infarction, because the muscles are already weak. Ischemic symptoms may be absent even at the time of getting the myocardial infarction. Cardiovascular disease may be secondary to autonomic neuropathy, as we already talked about. And silent myocardial infarctions are common in patients with diabetes. Silent meaning that there are no other symptoms of coronary artery disease. Diabetic damages arteries and makes them targets for hardening called atherosclerosis, and this predisposes patients to hypertension. Hypertension is one of the risk factors for coronary artery disease. And hypertension in diabetic individuals markedly increases the risks and accelerates the cause for cardiac disease. So if a patient is diabetic and they are also hypertensive, then there's a chance that they get faster into cardiovascular heart complications. Peripheral vascular disease, stroke, retinopathy, and nephropathy. So hypertension is a major risk factor for some of these things. And hypertension is simply increased blood pressure, which is, we say, more than 140 for systolic and more than 90 for diastolic. Of course, there are other factors including age that should be taken into consideration, and blood pressure is not just a one reading. It should be taken several times, probably on separate days, to diagnose hypertension. So let us now just compare the risk of hypertension between the two types of diabetes, between type 1 and type 2. In type 1, it is present after several years of diabetes mellitus, but you will notice that in type 2, it's mostly present at diagnosis of diabetes. It affects about 30% of patients of type 1 and about double of patients in type 2, that's about 60%. In type 1, it is secondary to nephropathy, the kidney damage, and type 2 due to insulin resistance. And in type 1, it's mainly due to reactivation or activation of the renin-angiotensin system, whereas for the type 2s is due to sympathetic nervous system. So those are the differences of hypertension between the two diabetic groups. We also have dyslipidemia, which is also a risk factor for cardiovascular disease in diabetics. And the major abnormality here is decreasing high density lipoproteins and increasing triglycerides. Hello, high density lipoproteins is the most constant predictor of cardiovascular disease in diabetics. So basically, those are the risk factors and the presentation of cardiovascular disease in diabetes. So this sums up diabetic cardiovascular disease. As we have said in summary, there are 4 conditions contributing to cardiovascular artery disease, and these are atherosclerosis, microangiopathy, diabetic cardiomyopathy, and cardiac autonomic neuropathy. We have also talked about several risk factors of cardiac disease in diabetics. So let us now move to cerebrovascular effects of diabetes. These patients must be told in no uncertain terms that their diabetic control, their sugar control, should be at the minimum if they have to delay or even get out of those complications. So now let us go to the second of the macrovascular complications of diabetes, and that is cerebrovascular effects. Glucose usually stiffens the red blood cells, but it also makes platelet aggregation easier. Platelets in type 2 diabetes adhere to vascular endothelium and aggregate more readily than those in healthy people. This has been identified as one of the mechanisms for enhanced arterial thrombosis that we see in type 2 diabetics. And therefore, this now leads to transient ischemic attacks. So those are small strokes that happens in these people, and then of course eventually will cause CVAs or strokes. People with diabetes are 2 times increased risk of cerebrovascular disease compared to their non-diabetic counterparts. So this figure shows just a cascade of the pathology of cerebrovascular accidents. As we know, diabetes with its complications of atherosclerosis and hypertension leads to obstruction of blood vessels in the brain, leading to either ischemia or hemorrhage, and this leads to stroke. So the eventual thing is stroke. We know that the key causes of cerebrovascular disease are abnormal lipids and high blood pressure, both of which contribute to atherosclerosis. So in summary, cerebrovascular disease is caused by 2 main things: abnormal lipids, which leads to atherosclerosis, and high blood pressure that leads to hemorrhage. So let us now go into the third macrovascular complication and the final complication of diabetes, macrovascular complication of diabetes, which is peripheral vascular disease. Peripheral artery disease is due to narrowed arteries that reduce blood flow to the limbs or to the extremities. Some of the signs and symptoms of this include decreased pulses, and the notable ones are dorsalis pedis and posterior tubule. These 2 are predictors of major macrovascular and also microvascular complication of diabetes. At the same time, we have intermittent claudication, and this is shown by pain in the buttock, the thigh, and calf muscles when walking because of the increased need for oxygen, which is not there because the vessels are already blocked. Then we have gangrene and amputation, and this is due to extreme occlusion of the arteries. So there are some risk factors for peripheral vascular disease. There are quite a number. So some of them are smoking, diabetes itself, obesity. If you have a mass index of over 30, then we have high blood pressure, high cholesterol levels, increasing age, especially after 50 years of age, a family history of peripheral vascular disease, heart disease, or someone who has already had stroke. So signs and symptoms, I think we've already talked about them, but one of the things is painful clamping of the muscles. It could be hip muscles, thigh muscles, calf muscles when walking or doing some exercise. Then leg numbness or weakness, coldness in the lower leg or feet, especially compared to the other side, sores on your feet, toes, legs that do not heal, a change in color of the legs. So all these are the things that you need to look for when you're examining these patients. Hair loss or slow hair growth on the feet, slower growth of toenails, shiny skin, and for men, erectile dysfunction. And then of course eventually we get gangrene that leads to amputation. So just a brief mention of the diabetic foot. We will talk about this later as we go into microvascular complication of diabetes. The diabetic foot can be a result of peripheral vascular disease as well as neuropathic disease. This slide shows the differences in presentation between the two, and you can see the major differences. If it is vascular, you have ischemia, it's due to no blood being supplied, but in neuropathic, the nerves are not working, so patients will present with numbness. Then we have intermittent claudication in vascular, and then weakness of intrinsic muscles causing deformities. Remember, these muscles have not been supplied by the nerves, so they're not working properly, they're dysfunctional. Then for vascular, you have healing delayed because of poor blood flow and high sugar levels. In neuropathic, the trauma may not be noticeable. Someone may get a very big trauma, but it's not painful, so they may not even present to hospital early enough for treatment. Screening of macrovascular complications. We have talked about this on and on, and one of the things you need to do, of course, is examine pulses for cardiovascular disease, and we've talked about two pulses, that is dorsalis pedis and posterior tibial arteries. And then do lipid profile, do the ECG for the heart, and of course monitor the blood pressure. And so we come to the end. So in summary, we have talked about macrovascular complication of diabetes in this session. The main factor in this is the duration of diabetes and diabetic control. Then of course we have the risks of hypertension, atherosclerosis, and dyslipidemia as being the major risk factors here. And then we've said that the foot ulcers are caused by both peripheral vascular disease and neuropathy. See you in the next session.
That sums up today's episode on macrovascular complications of diabetes. Join us next week for another session on microvascular complications of diabetes. Until then, stay safe.